The last part of this lecture series is going to talk about vascular disorders. In this section, we're going to talk about aortic aneurysms, acute arterial occlusion, and acute limb ischemia, and we'll also talk about acute deep vein thrombosis. Starting off with an aortic aneurysm. So an aortic aneurysm is a dilation or outpouching of a blood vessel, okay? So vessel gets dilated, stretched out, right? And it can dissect. So what happens is the vessel wall tears and blood fills the space between the tunica intima and the tunica media, causing them to separate. So remember, your vessels have three layers, right? Your tunica intima, the innermost layer, right? The tunica media, the muscular layer, and the outer layer, which is the tunica adventitia or the tunica externa, right? When that vessel starts to balloon out, the pressure and turbulence within that can cause a tearing in the tunica intima, and then blood is forced to be into the space between the tunica intima and the tunica media, and this can cause extension of this tearing down the aorta, okay? So dissection is when you have tearing down or separating down the layers of those down the layers of the aorta. Some of the risk factors for aortic aneurysm tobacco use: high blood pressure, which I have on there as high blood pressure and hypertension, congenital heart disease, and then connective tissue diseases like Ehlers-Danlos syndrome or Marfan syndrome. Okay, your aortic dissections can affect a couple different places. So you can have an aortic aneurysm / dissection that could dissect in the ascending thoracic area, right? So the ascending aorta. You could have it in the descending thoracic aorta, and then you could have it in the abdomen and or the abdominal aorta, right? So ascending, descending thoracic aorta, right? And then down in the abdomen. Okay. The ascending aortic aneurysms are generally going to present with sudden onset of unbearable pain. This pain can be in the chest, the neck, the throat, the jaw, or the face. They typically are going to have blood pressure differences greater than 20 millimeters of mercury in each arms, and they can have acute neurological changes and feelings of impending doom. In the descending area, they often will have sudden onset of unbearable pain as well, usually in their flank, back, abdomen, lower extremities. They can have blood pressure differences across their extremities, but often in that abdominal or the descending thoracic abdominal area, they're going to have poor perfusion to the lower extremities. Okay, this could be, depending on how far down the dissection goes, could be the issue. It also could be that blood is being forced into that lumen, right? So poor perfusion in the lower extremities is going to look like pulselessness, pallor, right? Things like that. And for both patients, a feeling of impending doom is common. Okay, the patients who have an abdominal aortic aneurysm, you may feel a pulsatile mass. If you felt it, don't touch it anymore. And if you see it, don't palpate it at all. The management for these patients is going to be to immediately contact medical control because they need a thoracic surgeon, right? Or not a thoracic surgeon, but a vascular surgeon, right, to take care of this aneurysm. So contact medical control, let them know you're coming in immediately, right? You're going to put IVs in this patient. You're going to do a 12 lead and keep them on continuous cardiac monitoring. Oxygen will be appropriate. If their pressure is bad, fluids are indicated, and then please give them something for pain, okay? And rapid transport is going to be the key. This is not something you can fix in the pre-hospital setting. Other things that you may deal with are going to be acute arterial occlusion and DVT, so I want to make sure that you guys can differentiate between these. So an acute arterial occlusion, right, is going to be the sudden disruption of arterial blood flow that occurs due to a thrombus, embolus, tumor, or direct trauma. So thrombus, a clot forms in the vessel itself, right, and occludes blood flow going down. An embolus, a clot traveled from somewhere else, for example, like a patient who has AFib, the clot traveled from somewhere else, and it ends up somewhere and it occludes the blood flow into that area. A tumor, right, which is going to occupy space and can compress vessels, or direct injury like a crush or compartment type syndrome. These patients are going to present with what looks like if it's affecting the leg, it's going to look like a dead leg. Why? Because the artery that delivers oxygen and nutrients is occluded. And so if you had no oxygen or nutrients being delivered to your body, it would kill you, right? Well, in this case, it's isolated to just the leg, so it looks like a dead leg, right? The assessment findings: pain, pulselessness, pallor, paresthesia, paralysis, okay? A lot of these patients that end up with these acute arterial occlusions have history of peripheral artery disease, commonly seen in patients with like diabetes or COPD. They also could have things like AFib, like I mentioned before. The issue for this is that, one, they could lose their limb. They also have a risk for limb infection as a result. Signs and symptoms of an arterial occlusion: claudication, which is like pain in the calf when you flex, leg fatigue, poor cap refill, and then dry, scaly skin. Those are going to be signs of your peripheral artery disease, which is going to put you at risk for acute arterial occlusion. The management is going to be to identify. So you guys know we get on you all the time about looking at the patient's legs. If you don't look, you will not find. Okay. Supportive treatment is going to be en route. You want to make sure that you're checking blood pressure in both arms, because these arterial occlusion presentations in the leg can actually also be due to a dissecting aneurysm, and then provide rapid transport. Remember, life, limb, or eyesight, rapid transport. And this is going to be one of those things that's going to, if we don't restore blood flow through those limbs, the patient will lose them. Okay, so rapid transport is going to be appropriate. Alternatively, you could have something like a deep vein thrombosis. So in a deep vein thrombosis, blood flow can continue to come into the extremity, for example, if we're talking about an extremity, but it can't get out through the veins. So it comes in under high pressure in the artery, but cannot exit through the veins. So some of the things that we worry about causing it: thrombophlebitis, so inflammation of an area due to a damaged vein, right? And you get a clot in the vein. And those thrombophlebitis can be superficial or deep, okay? One of the life-threatening complications of DVTs is a PE, because that clot that forms, let's say, in the leg can break off. And when it does, it goes into the heart, and then the next place it ends up is in the lungs, and then it gets stuck in the pulmonary arteries. Some of the risk factors for this: venous stasis, so where blood is being still, right? Venous stasis, so if you're pregnant, immobile, obese, or you have heart failure, blood stays still in places longer, and that can lead to clot formation. Damage to the vessel lining, trauma, inflammation, IV access, or IV medication administration, and then anything that's going to increase your clotting risk, things like cancer, dehydration, the use of contraceptives or other hormone therapy. We're talking about hormonal contraceptives here. All right. In these patients, they're going to have swelling, right? Pain, tenderness, right? So you'll notice this leg that's got the blue arrow and the left leg in the second picture, right? Those legs are swollen, they're red, they're well perfused. Why? Oxygenated blood under high pressure still gets into the extremity, but it can't get out through the vein, okay? So you get swelling. It hurts with that swelling, right? So you're going to get pain and tenderness. They will often have a positive Homan sign, which is pain in the calf with dorsiflexion of the foot. So if they pump their foot, they have pain in their calf. Management for this patient is also going to be to identify the signs of that DVT, okay? Provide supportive treatment en route, and then monitor for signs of a pulmonary embolism.